Thank you so much, everyone. And I am supposed to talk on this subject of Indian reality and insulin initiation. So, realities of diabetes management, we are all aware that with passage of time, the management of diabetes has become patient-centric, whether we talk of oral drugs, whether we talk of the lifestyle changes like diet. The recent guidelines, they focus on personalization of the diet changes, or whether we talk of the initiation of insulin. So whenever we talk of initiating insulin in our patient, then certainly we will have to think about the patient who is under consideration, especially when we are talking of our context, that is in India. We know that we consume a lot of carbohydrates, we have got high prandial glucose levels, and we initiate insulin quite late. So all these factors, they have to be kept in mind before we try to initiate insulin. And not only these factors, but the factors which are there in the minds of the patients, which are responsible for inertia, or which are there in the minds of the physician, like the incidence of hypoglycemia, the myths around insulin, the cost factors, the interference with the lifestyle of that individual. All these factors have to be considered before we pick and choose the insulin which has to be given to that individual, because we are now having a lot of choices as far as the insulin is concerned. As far as insulin is concerned, we know that it has got the maximum glycemic efficacy if we are comparing it with any other oral drug or even the injectable GLP-1 RA. It comes handy whenever we talk of situations like catabolic situations, tuberculosis, septicemia, GDM, inpatients, perioperative, various sort of situations wherein insulin comes to our mind, and as per the guidelines also, they have to be initiated as the first choice. So with that background, and with the background of the current guidelines, which have got consensus of initiating insulin with basal. Now, most of the guidelines, rather all of the guidelines, they talk of initiating insulin with basal. But with that thing in background, my contention will be, in Indian scenario, should we have only that choice, or can we think of something beyond that? So now with that intention, if we see the response rate of the patients achieving our target as compared to non-Asians, we know that we achieve targets in lesser proportion as compared to our counterparts. Now what we do, so we start with basal insulin, and then in deal to achieve HbA1c target, we increase the dose of basal to optimal or maximal dose. And that is done because we know that once we are lowering the fasting blood sugar, the peaks of the prandial will also go down. But in process of doing that, and in trying to achieve that PPG control also through basal, we'll end up in situations where the person will start having hypoglycemia. So with that thing in background, can OD basal insulin is suitable for Indians who consume lot of carbohydrates, or can it really control the prandial glycemia, or is it suitable for patients wherein we delay a lot in initiating insulin, or can it offer convenience in terms of number of injections to control the prandial glucose as well? So these are the questions which will be obviously asked once we are talking of the basal initiation. Now with that thing in mind, there is another option which I will be discussing, and that is a combination of the aspart, the fast-acting insulin, and a very long-acting basal, that is the degludec. And combining these two in one solution, wherein they maintain their individuality, at the same time they maintain their PK and PD once they are injected into the subcutaneous tissue. So with that sort of phenomena where these two drugs, they try to have a near physiological control of the blood sugar in our patients once injected, can this be one choice? We talk of the phase 3 clinical programs the IWSP has undergone, various sorts of situations, various sorts of countries, and situations like Ramadan, where it has been tried and it has been found at least non-inferior, and the superiority comes in form of the incidence of hypoglycemia, which obviously sits in the driver's seat. We know that it is responsible for the adverse cardiovascular outcomes. So once we compare this initiation with the basal insulin initiation, then we can see there is superiority of the HbA1c reduction. And this is because of the virtue of the presence of aspartate. And that is the thing which is also responsible for bringing in the prandial glucose significantly down as compared to basal insulin. And that is an obvious thing. But the thing is that it comes without paying price for nocturnal or any confirmed hypoglycemia. And this is something which is heartening. If we are trying to compare it with the basal plus sort of situation, then once again we can see that there is similar HbA1c, fasting blood sugar and PPG reduction, but once again there is significant decline in the nocturnal hypoglycemia, and there is lesser dose of insulin which is required to achieve the same HbA1c goal. So these are the advantages with the use of co-formulation, which can be used in initiating insulin in our patients. So this was about the randomized controlled trial. Now, once we give that liberty of using this co-formulation in the common world situation, so this ARISE trial basically studied the same pattern. It was non-interventional trial, multi-center, multi-country, and that basically was trying to observe the changes in terms of the fasting decline or the HbA1c control, hypoglycemia, and various other aspects, making the physician free to use as per his decision, knowledge, and requirement of the patient to add on the co-formulation in real-world practice. So this was the baseline characteristic, very close to what we really see when we initiate insulin. HbA1c somewhere around 9.8. And the duration of diabetes somewhere around 13 years, age 58 years, and all these factors. Now the patients, they were shifted onto or added on to co-formulation. So what were the percentages wherein this co-formulation was added? 35% of the patients where it was added was OADs. In 21.8% where only basal was in use. In 8.2% patients along with GLP-1 RA, or shifting from basal bolus in 13%, 21.9% patients where the premixes were shifted onto co-formulation. Why this was done? This was done because the physician basically was wanting to improve the patient's glycemic control. That was the highest requirement. And the other requirements were lower rate of risk of hypoglycemia, flexibility in the dosing regimen, fewer injections than basal bolus, no reconstitution as against premixes, changes in coverage status favoring IDAG-ASP, and there were other simple reasons why the physician chose to shift to this co-formulation. Now the choice was to start with 1 or 2 injection, and we can see that it was nearly 50-50% where the physicians, they shifted to twice daily or once daily co-formulation. So then coming to the results, the changes in the HbA1c, we were expecting that in Indian scenario, because of the factors already mentioned, we should be having a good sort of HbA1c decline. And in India, we can see that is 1.6% decline, much more than other countries, excepting for Saudi Arabia. So we were responding much better to the co-formulation. If we talk of the changes in the HbA1c, wherein the different comparison between different groups where the co-formulation was added, maximum decline was seen when it was added to OADs, and specific to mention is basal bolus. We know that basal bolus is a gold standard, and herein, whenever we have RCTs, then twice daily use of co-formulation against basal bolus is found to be equivalent in terms of HbA1c reduction. But here we can see that once the patients are shifted from basal bolus to the twice daily co-formulation, there is a better decline in HbA1c, proving the real-world superiority of the use of co-formulation. And this has happened because of lesser chances of hypoglycemia, more confidence and in the hands of the physician, so that he was able to up-titrate the dosages of co-formulation. So that comes as an advantage in real-world sort of situation. If we talk of the fasting plasma glucose decline from baseline in various countries, we see a modest decline of nearly 51.9 milligram percent from the baseline in Indian context. Coming to the important aspect, that is the non-severe hypoglycemic events prior to the start of treatment as compared to end of study treatment, we can see that excepting for GLP-1 RA, rest of the arms, they were having less of non-severe hypoglycemic events. And now if we compare it with the severe hypoglycemic events, we can see that there is a significant change prior to the end of the study, and probably these values of these numbers were insignificant. That means shifting on to co-formulation basically led to minimalistic severe hypoglycemic events, making it safe to include in the armamentarium. Another important aspect, which is very important as far as the Indian situation is concerned, because most of us pay from our pocket for our expenses for medical treatment. And here we can see that there is significant reduction in the resource utilization, whether it is the self-reported outpatient visits, whether it is self-reported emergency room visits, or whether it is the work days missed by the patients to take care of their medical conditions. Everything was significantly affected. That saved money and obviously led to convenience. So all these factors, they become important in our day-to-day life. So once we are using this co-formulation, probably that is helping patients in more than one ways. So if suppose I conclude the ARISE study, then it was effective in HbA1c reduction, effective in the fasting blood sugar control, it improved the safety, and of course, there was a better resource utilization. Now let us see what really happens on the ground once we use glargine 100, glargine 300 as against co-formulation. So do we have some data here? So I'll be comparing that in the next slide, but before that, I'll mention that IDEG-ASP becomes prudent choice in Indian reality, especially in patients, those who are on multiple OADs and those who are on only basal. Because we consume a lot of carbohydrates, we have higher prandial glucose, and both these have to be simultaneously controlled so as to reach to the goal of HbA1c control, at the same time decreasing the glycemic variability and putting the patient's blood sugar values more in time in range. So these are the advantages which we can think of with the initiation and up titration of IDEG-ASP. Now coming on to the question which I was talking about, that in real world situation, if suppose we observe all these three options, then what do we see? We can see that there was the maximum decline of HbA1c with the use of co-formulation, that is the blue line, coming from 9.61 to 8.09. So that led to this statistically significant decline in HbA1c as compared to U100 and U300 arm. If we talk of the changes in the fasting blood sugar and PP blood sugar, once again we can see that there is significant better fasting blood sugar reduction with IDEG-ASP as compared to IGLAR U100 and 300. At the same time, there is significant better PPG reduction with IDEG-ASP as compared to IGLAR 100 and glargine U300. Talking of the insulin dose which is required to control, significant increase in insulin dose requirement in the IGLAR U100 arm and non-significant increase with IGLAR U300 and IDEG-ASP arms. And if we talk of proportion of patients reporting hypoglycemia, no significant difference in hypoglycemia occurrence between all the three groups. So this is what is the real world situation once we are using IDEG-ASP. So to summarize my talk, in tune with the Indian realities of diabetes management, IDEG-ASP is a prudent choice for insulin initiation as it offers total control and can help achieve glycemic goals with safety, especially if we talk of countries, those who consume a lot of carbohydrates. And therein, the plasma or the postprandial glucose, which is an independent factor, which is an important factor, which leads to less control of HbA1c. If suppose we can address to both the fasting and prandial, we can bring more number of patients onto goal. At the same time, the glycemic variability will go down. At the same time, more number of glucose values will be in range. In randomized clinical control trials, OD IDAG-ASP has been shown to be superior as compared to OD basal insulin, while still offering numerical reduction in the risk of hypoglycemia. And OD IDAG-ASP has also shown similar glycemic control as compared to basal plus regimen at significantly lower dosage and while offering significant lower risk of nocturnal hypoglycemia. So when used as per local clinical practice, results with IDAG-ASP use corroborate with those seen in the RCTs. Thank you so much for your patient hearing.